Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I am here with the brilliant neurologist, Dr. Michael Wong. He is a long time friend of mine, as you'll hear us talk about at the very beginning. And I'm bringing Mike in, so I think I'm due for a refresher on my neuro examination. I just wanted to kind of run through what's in a neuro exam. Is my neuro exam up to snuff? Am I doing this right? Are there big things that I'm missing? And we dive into that. Mike is always an interesting person to listen to. He is smart in a lot of ways. He is a brilliant clinician, boarded neurologist. He is also the founder of a wildly successful group of neurology practices where he has sort of poured his heart and soul as well as he continues to practice. And he's a neat guy. He's got an interesting way of looking at practice. I really like his systematic approach to neurology. He very much believes that there's a checklist in neurology. And if you follow the checklist, you're going to largely come to your answer. And I think that's what appeals about neurology to him. And also, I think it's always fascinating to hear how he sort of looks at it. And I go, oh man, I wish I saw medicine in that much of a systematic way. I would like to be more like that. And so anyway, that's what we get into today. Guys, without further ado, let's get into this episode.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Mike Wong. How are you, my dear old friend?
I'm super, Andy. How are you?
I'm doing really well. It's so good to spend time with you. You and I go so far back. You were probably the first person in veterinary medicine that made a real impact on me. I think I've told you that before. When I started in vet school back in 2004, you were in your fourth year and I was in my first year, and you had just started a new club called the VBMA, the Student Business Club. And we were like in our first day and we were hearing from all the clubs, and you were like, this is what we're doing. And you can learn how to run your own hospital and kind of make your own team and make your career what you want it to be. And I was like, I'm in. Like I am in. And now I look at you. You are the founder of Southeast Veterinary Neurology. You guys have 4 locations. You've got 9 veterinary neurologists, 9 residents. You've got 2 interns. It's just this continuously sort of slowly kind of growing organization. But you guys, you have a phenomenal reputation. You know, you've got some neurologists that I know who are also good friends of mine. You've got one of my classmates, at least one, that are there. But oh man, you have built this thing up, and you are one of those veterinarians who is an outstanding clinician, and you're still very much in practice and also a business owner. And so anyway, you've always been someone that I've admired. Like I said, for those who don't know you, you are the founder of Southeast Veterinary Neurology and a boarded and practicing neurologist. So anyway, thanks for making time to be here. I know that you've got a lot of things on your plate.
Yeah, no, I appreciate that. I tell a similar story, but from the other side of the stage. It was this VBMA introducing our things, and Andy was the first one that he actually came up to me at the end of it. And obviously everybody knows how that turned out, where, yep, I may have started it at Florida, but he made it into what it is and took it to entirely different levels than what was ever expected back in 2004. So.
Well, thanks, buddy. Yeah, it's been a great friendship. So I wanted to talk to you today a little bit about sort of the neurologic exam. And I think my idea here, I kind of want to circle back around. And, it's been a while since I've had a good breakdown. And there's a number of different components to the neuro exam. But I saw a patient recently. It was this dog, and it was sort of a post-traumatic dog. And I think the dog got kicked, and it just was not doing right. And so it was kind of obtunded, and I was kind of flipping his feet over and everything. And I thought, I wonder if I'm missing anything here. I wonder if my exam is really where it needs to be when I'm sort of trying to sort out what's going on with these patients. And so I think if you're okay with it, I'd like to sort of talk to you about both sort of the details and also sort of the philosophy that you have as you sort of look at a neuro exam.
Sure. Happy to do so. So was it little dog, big dog?
It was a little dog. It was, it was like a little Chihuahua dog that I imagine it was kind of one of those kind of coming around the corner. Somebody was walking and the dog was sort of there, and then sort of a bonk. But again, it's got sort of the big sort of, it's not hydrocephalic, but it kind of looks that way, sort of really big noggins. And I'm going, is this dog okay? Or is this just how he is? He kind of is like, hey, the chicken from Moana when I saw him, if that makes sense.
Yeah, it makes perfect sense. Yes.
Walk me through it. When you sort of, they bring a case into your clinic, just sort of an ADR kind of case, you're getting this for some reason. How do you kind of look at those sort of general, vague, possibly neuro presentations?
Yeah, well, I guess the thing that I've always liked about neuro, and I think what neurophiles, like about neuro is it's so systematic. And, some can say, hey, that's boring. For someone like me, where I like, I do A, then I do B, then I do C, it simplifies the thought process. So,
okay, I like this. I'm here for this.
For me, it starts with signalment and history. So even before we really started talking, it's a Chihuahua, presumably young, was presumably normal beforehand. So we're getting our history, but signalment and history, normal beforehand, young adult Chihuahua. Then it's kind of the general physical exam. How much of this dog being dull is something else systemic? Again, in this example, if the owners are saying, hey, my dog was normal, my foot hit it, the door hit it, my big dog hit it, whatever it was that hit it, we start thinking, we're not thinking quite as much, well, gosh, could there be something else metabolically going on? The history is pretty telltale that, hey, this is trauma. So if we're going down that we know that this is trauma, kind of to me, the next step is making sure there aren't other polytrauma, other life-threatening systemic things, pneumothorax, hemoabdomen, stuff like that. Again, depends on what sort of trauma we're talking about, whether we're hit by a car, kicked by a horse, or whether it's, in your example, foot ran into dog.
Let me flip it up on you a little bit here and say, let's say that I've got one of the neuro cases where I'm seeing hind leg weakness, things like that. Sure. And so I'm looking at it. There's, I'm always going to start looking and sort of say, is there nerve damage here? Is there pain here? Things like that. Can you talk to me a little bit as if you're looking at sort of a trauma case or something like this? How do you start to differentiate what is pain versus what is a neurological sort of impairment or damage?
To me, they're different and there's overlap. So if I'm understanding your question of, is this dog not walking because is that what you mean? Is this dog not walking?
Yeah, exactly right. Or let's say it's unsteady in the back end, and I go, I want to make sure that I'm separating here and say, to me, I go, oh, this dog is clearly, painful in its back. Sort of thinking around the examination around that, what are the things that you would want to really dig into to make sure that you have a clear picture of what's happening?
Yeah, so I guess if I'm understanding correctly, so when I have a dog where symptoms of pain will be reluctance to move, or the way that they move, they're guarding, they're not walking freely, versus when I hear, is this dog neurological? I guess I'm thinking more incoordination, ataxia, etc. Usually what I'm doing in my neuro exam, and granted, everything that's come into my hospital is here because someone thinks it has a neurological problem, whether it's the primary veterinarian or the owner. I'm trying to answer the question, is this neuro or not, at the very beginning. Whether it's my team has already taken a history and then I'm going and talking to the client and starting my exam, or whether I'm going straight into the exam room myself and taking a history, like when I was an intern resident, et cetera. And I'm sure how many veterinarians practice where they're going in and, asking the owner their own questions. But for me, I see so many interns and young veterinarians and students that the first thing they do is, I'm starting my neuro exam. And I have always tried to take a hands-off approach at first as I'm talking to the client, whether I'm taking the history or whether I'm just asking my clarifying questions. If it's a little dog that's on a lap or in a stroller, hey, do you mind putting, Fifi on the ground? If it's a cat, hey, let's let your pet out of the carrier. And just while I'm talking, I guess a couple things are happening. One, that pet's relaxing a little bit. It's going to have a better experience. I'm probably going to get a more accurate exam, probably less likely to get bit, whatever. But I'm letting that patient sort of relax. Next thing that it's doing is many animals will start exploring the room. And for me, that's two parts of my neurological examination, maybe even three parts. I'm assessing its level of consciousness, its a level of alertness. How's it interacting with the room? Is it exploring? Does it recognize, hey, I'm stranger, mom's there? Is it recognizing this is the front door, this is how I get out of here? Level of alertness. And the second thing that I'm assessing, if the pet is cooperating, is its gait. Some of them will start walking around the room, and a lot of times from gait, I can say, is this dog walking in circles? Does this dog have a head tilt? Is it sort of listing to the side? weak in any limbs? Is it dragging any limbs? Can't it walk, etc.? And that's sort of already changing my thought process. Granted, I already have a history. I've got a presenting complaint, so I'm already kind of tuned into, hey, I think this is a brain problem, a vestibular problem, a spinal problem, whatever. So I'm already thinking that way, but the pet is giving me clues as I'm talking to the owner based on how it's moving around the room. And when I said, maybe three things, like if it's painful, sometimes it will show me evidence of pain, whether it's its posture, so like a dog with neck pain, how they kind of hold their head low, they'll arch their back. There's a lot that I can tell before I even set hands on a patient and kind of in my history. And that's not the end all be all, but it's a lot of information right at the get-go.
Are you ever wrong on this at this phase, Mike? Like, do you ever see, I mean, you're like never, but do you ever see a patient and you're like, oh, this doesn't seem like that big a deal. And then when you get deeper down, you go, oh, this dog was masking, a lot of the symptoms? Or do you ever see dogs that you think, oh my goodness, and you go, no, this is not nearly as severe as I thought it was when I saw the dog walking or when I saw the cat coming out of the character? Or is it usually a pretty good indication? You can fairly well judge level of severity when you're looking at this pet?
To answer the first question, I'm wrong all the time. And having 9 neurologists, having residents, I don't want to say it's humbling, but you learn a lot. And so I'm wrong frequently. I guess my philosophy is I'm wrong a lot less today than I used to be. I know as much as I do now because of all the times I was wrong, 5 years ago, 10 years ago, 15 years ago. A more clinical answer versus, the Mike Wong philosophical answer is yes, we're typically right. I mean, that's what I like about neurology. Right. That's what I like about veterinary medicine is it's very seldom that the patient is lying to us. If this dog is holding its head low and screaming in pain, I'm very confident, hey, its problem is likely in its neck. If this dog is having seizures and walking in circles to the left and does not have a menace response, I don't know, I do this every time I say menace response, but
you hold your hand up to your face.
Hold my hand up to my face. Has a menace deficit in the right eye. It almost certainly has a problem in its left forebrain. If it's perfectly fine in its thoracic limbs and it's dragging its pelvic limbs and has normal reflexes in its pelvic limbs, the problem is in the T3L3 spinal cord. So that's the nice thing is the neuro exam, I won't say never lies, but seldom lies.
So let's get into this exam. And one of the things I always love about you is you're very systematic in your approach. And so I am confident that you have a way that you approach these exams. Once you put the pet on the table, how do you organize your neuro exam?
The vast majority of patients, I try to be systematic because you're less likely to make a mistake. You're less likely to forget something. I kind of walked you through in my taking a history, in my hearing the history from one of our room nurses. I'm watching the dog for level of alertness. I'm seeing how the dog's moving around the exam room if that's where it is. But now once we're up on the table, I know lots of neurologists that like to sort of start at the nose and move back towards the tail. So mentation, and then they'll do cranial nerves. So cranial nerves, again, there are 12 cranial nerves. We're kind of assessing menace response, PLR, palpebral reflex, facial symmetry. I'll always change the dog's head position to see if I can elicit any abnormal nystagmus, kind of with the gag reflex. As I'm opening the patient's mouth, I'm feeling the face, feeling facial symmetry, feeling jaw tone, looking at the tongue for symmetry, and then checking a gag reflex. So kind of a lot of stuff happens right at that same time. So from there, I won't say it depends on what they're presenting for, but let's say it's a dog that is here for not walking. Many times, if the pet is already up on the table, I will check postural reactions. And then I want to see the pet walk. Sometimes I'll check postural reactions again after watching the gait. Kind of all depends on, is it a big dog? It's already on the ground. I'm going to watch it walk. So those things kind of all happen, either A then B, sometimes B then A, but I'm doing postural reactions, gait, and then checking spinal reflexes, cutaneous truncal reflex, perineal reflex, checking reflexes, and then palpating the dog for any evidence of pain. So those are the big parts of the neuro exam. Again, I try to be systematic. There are certain things that might change the order that I do things. Like big dog that's already on the ground, it's already laterally recumbent. I might check its reflexes before getting it up to check postural reactions and have the dog walk. I guess less number of times I have to ask my team to, pick up a 110-pound dog, the better. But I guess while we're on that, to me, that would be a pearl of wisdom or a common pitfall that I often see, or I'll take a phone call and, hey, this dog can't walk, but they really haven't tried to get the dog up. And once we get the dog up, alas, the dog can walk, or, there is some movement. So I guess that would be one of my, tidbits for the listeners is it's important not to just look at it, hey, he can't get up, to try and get the dog up, whether it's...
Yeah, get him up and see what happens.
Exactly.
Okay, when you start talking about postural reflexes and things like that, Mike, what are the pieces, when you see cases that get referred to you, what is the most commonly missed piece of information coming in? So are there parts of the neuro exam that you think general practice doctors are most likely to leave out? And then when they come to you, you say, oh, well, we got more information here. You might not say, here's the diagnosis, but you say, this was a beneficial thing that I did not see coming in on referral, or that I feel like GPs are not uncovering when the pet is at their practice.
It's hard to generalize all GPs. I mean, there are some that
Sure.
are fantastic at neurology and some that are less comfortable. There are the times where all that's happened is, hey, I checked postural reactions, and that was the entirety of the neuro exam. And basically they've said, hey, there's a postural reaction deficit. It's neuro. I'm sending to Southeast Veterinary Neurology. There's nothing wrong with that, but for those listeners that are looking to, hey, I want to be able to do more than that. For getting good at a neuro exam, it's like anything else. I want to be better at tennis. I got to play more tennis. I saw you do your first muscle up the other day. That was, yeah. That's something that took time and practice. So I'm afraid that there isn't going to be in this podcast the one sentence that I say that everyone's like, aha, now I've got it. Neuro's easy.
The thing.
That's
the whole profession lurches forward
exactly
because of this line from Mike Wong.
It's a function of practice. And, sure, the knowledge base, the books, there are tons of videos out there at the Cornell website that has lots of gait analysis, but just doing it over and over. And in my internship, it was, whether it was a neuro patient or not, when I did a general physical exam, I was doing a neuro exam.
I got a full neuro,
And when I was in my residency, whether it was my patient or not, it was getting a neuro exam. So practice is probably the biggest thing. And that's what's beautiful about neurology. It's so pattern recognition. I'm feeling bad because I don't want the take home to be like, in order to be good at neuro, you've got to
just do neuro over and over again.
But that's when it gets simple, is when it's pattern recognition of, hey, this dog walks like this. It must be a C6T2 myelopathy.
Well, Mike, thanks so much for being here. Where can people find you online? Where can they learn more about Southeast Veterinary Neurology?
Our website is sevneurology.com. So Southeast Veterinary, and then the whole word neurology.com. We're on pretty much every social, LinkedIn, TikTok, Instagram, Facebook, all that jazz.
The whole
everything.
Collection.
Most of that's your fault, but
yeah, I pioneered the path, and now we all regret it. We all wish I hadn't done that, but here we are.
We do a conference every year in April for general practitioners. So we do one for neurology residents, but then over the weekend we do a general practitioner track neurology conference, and that's April of every year. It's in Fort Lauderdale this year. We have it in person and online. So 4 to 6 weeks from now, when this goes out, I'll be sure to get that for you.
That sounds good. Well, I will put links in the show notes for everything to get all set up. Mike, thanks again for being here. Guys, thanks for tuning in, everybody. Take care of yourselves, gang.
Thanks, everyone.
And that's what I got. Guys, thanks for being here. Guys, thanks to Dr. Mike Wong at Southeast Veterinary Neurology for making time. Gang, take care of yourselves, everybody. I'll talk to you later. Bye.